So today we are going to talk about pre-prosthetic surgeries. And in today's class, we will discuss about the introduction of pre-prosthetic surgery and what it is. That means its definition and aims for pre-prosthetic surgery, why we do the pre-prosthetic surgery and goals. And now in further classes, we will discuss about the classification and every procedure in detail. So as of today, the pre-prosthetic surgery is an integral part of oral maxillofacial prosthetics and surgery. Basically, you want to create a good environment for receiving a prosthesis in such a way that the prosthodontist will be able to give a proper prosthesis and provide a good environment for the prosthesis to stay. As the goal of prosthetic appliance construction is to improve functional aesthetics, and pre-prosthetic surgery actually enhances this. So before treatment plan and everything should have a coordination between a prosthodontist and an oral maxillofacial surgeon. We, as oral surgeons, we do not know what are the needs for prosthesis as in. So we need a prosthodontist guidance which way they want the the surface to be done. So coming to a complete denture, normal complete denture, there are ideal requirements for a denture restoration. And in most of the cases, we will not have these ideal requirements placed or done clearly. So according to the Goodsell recommendation, an adequate bony support for the denture, that is adequate width, height, and loop shape, that pattern which we already learned has to be there. And the bone should be covered with adequate soft tissue. There is not enough adequate soft tissue over there. The denture or some prosthesis could apply pressure, and that will lead to damage to the site. That means soft tissue damage could happen. And ridge should not have any undercuts or sharp ridges. Or if there is undercut, that should be unilateral. That's what we normally do. That is all. When there are bilateral undercuts, you will not be able to take a proper impression itself. And even if you could take an impression, the denture or the prosthesis will be difficult to insert or remove. There should be, as we already know, there should be only single path of insertion and exertion. I mean, the removal of the denture, right? So, in order for that, we need to avoid the undercuts or sharp ridges. Sharp ridges, especially, could lead to pain of the site. And there should not be any body or soft tissue protuberances, like in your flabby ridges or tuberosities, like your mandibular tuberosities and palatal tuberosity. All these things should be removed. And it should have an adequate buccal and lingual self-guidance. We know for every denture to occupy the space, there should be enough sulcus there. And this S-shaped pattern in the lingual aspect and everything. So in order to have that, there are certain situations you should go for the pre-prosthetic surgery. And it should not have any scar patch that prevent the normal seating of denture. So we have to keep this in mind as well when you are doing a surgery. There is a possibility there could be any scar formation. So you have to do the surgery in such a way that there should not be any scar patch that preventing the normal seating of denture. And if there is already, maybe due to a previous surgery or mostly like a cancer surgeries or trauma, we have to relieve those scar bands or fibrous bands and provide a good environment for the denture to be placed. And no muscle fibers or flea should dislodge the prosthesis. It should be such a way that it should go down or up, such that you can place the denture and it's not dislodged from the actual position. And no soft tissue hypertrophies, which we have already talked about, like flabby ridges or something like which we face in our combination syndrome. So, what changes occurs once the teeth are lost, which we have to know. Basically, only after these changes, you have to think about the surgical procedures as well, right? So, no functional stimulation of alveolar process is happening. So, this option start. starts doing, and we know the maxilla goes inside and mandible goes outside. All these are patterns of resorption in case of our ridges. And then there is reduction of height of residual ridge. When there is resorption, clearly there will be reduction in the height of residual ridges. And an increase in interarch distance will be there. Basically, interarch distance will be increased and maxillary arch becomes narrower, mandibular arch becomes wider. Mandible is subjected to early atrophy and greater extent than maxilla. And for maxilla, the orthoporosity region will be projected up. So coming back to our pre-prosthetic surgeries. So what is pre-prosthetic surgery? A surgery performed to reform or redesign soft and hard tissues by eliminating biological hindrances to receive a comfortable and stable prosthesis. So, like I said, we are redesigning or reforming the soft tissues and hard tissues by eliminating the biological hindrances. So we are removing the excessive soft tissue or hard tissue or remodeling to receive a stable prosthesis. Okay. So what are the goals of pre-prosthetic surgery? So we know there are many, we'll discuss about it. There are many types of pre-prosthetic surgeries, and there should be some kind of goal for any surgery, right? So coming to the goals of pre-prosthetic surgery, there are mainly to modify the oral environment to render it free of disease and to make it for and possibly the function more compatible. I mean, basically, you want to give up or provide a good environment for the processes to be coming in, or provide a broad, flat edge form with vertical height minimum of 5 mm, provided by nearly parallel non-undercut bony walls and maxillary and mandible. So basically, at least a vertical height of 5 mm should be there for each upper and lower ridges, and it should be nearly parallel. You can't make it completely parallel, but nearly parallel with both the ridges, and there should not be any undercut or bony walls over there. And provide a firm, resilient mucosal covering. A thin mucosal covering or a flabby ridge could do damages to the denture, or it will lead to the damage to the soft tissue when there is thin mucosa, or if it is a flabby ridge or something, it could lead to the retrieval of, the falling of the denture or something like that. Basically, you won't be able to place a denture properly. And provide an ideal interarch distance, which is of 16 to 18 mm. We need an ideal interarch distance to keep your teeth in position. Basically, your denture should have a space to keep your teeth, right? So that's your ideal interarch distance, which is about 16 to 18 mm. And in severely bony deficient mandible, provide a bone bulk for strength and protection of neurovascular bundles and bony behind the mandibular canal. So we know about the mandible, and as they get older, it becomes very thin. And if there is no teeth also, it could become very thin in such a way that it is under some kind of pressure itself, it could break. So we should provide some kind of bone bulk for the strength, because when you're providing a denture or a prosthesis, that should have enough strength to withstand the pressure which is going to be applied over the denture by the mandible, by the occlusal forces. If not, the mandible could break. So in order to avoid that, you have to add on bulk, some kind of bony bulk to the mandible, or provide an arched palatal wall. We need a good arched palatal wall for the proper suction force of your upper denture. Without that proper suction force, that could fall off, right? So in order to avoid that also, or provide a post-tuberosity or have lanochium to enhance the posterior border seal and resistance of the denture. Freedom from neoplastic disease. Any kind of cancerous lesion has to be removed, or any kind of tuberosity increase has to be removed. And coming to the aim of pre-prosthetic surgery, to create a proper supporting structure for denture construction, also to rehabilitate the patient with best mastocytoid function, and to improve the facial aesthetic. These are all the major aims of the pre-prosthetic surgeries. Now, so we'll go to the classification and we'll stop the class for today by that, and we'll discuss further on the next class. Just on the basic classification, there is basic procedures and advanced procedure. We know that the basic smaller procedures comes under the basic procedure, and advanced procedure, which may include your orthoplastic surgery, which will increase the mandibular length, or when there is sleeve for surgeries to increase the maxillary width or height. All these things can be done. Basically, you are and you have to always keep in mind that the pre-prosthetic surgery is not only for your complete denture correction. It can be done before your implant placement as well. So when there are implants and when you want to place, especially implants over your maxillary region, and as the patient had, suppose the patient had lost the teeth long before, and there is a possibility of them to have a sinus approximation, which has to be increased. I mean, the approximation should not be there for placing a proper implant. So maybe we have to do a sinus lift to provide enough strength or space for the implant to occupy. That's also coming under the prosthetic surgery. Or coming to the implant placement of mandible, and then there is resorption, and the mandibular canal is very close to the septo. There is a possibility when you're placing the implant, you are going to irritate or damage the neurovascular bundle coming through the inferior alveolar canal. So there is a procedure called nerve lateralization, where in major surgical procedure, you can actually access the nerve canal and then retrieve the nerve and the whole neurovascular bundle from the side and place the implant, then relieve the nerve bundle. Which all could come under advanced procedure. And the basic procedures could be like your basic alveoloplasty or post extraction, constriction of your denture, I mean the ridges and everything. So another classification will be alveolar ridge correction, alveolar ridge extension, and alveolar ridge augmentation. These are majorly like your bridge has to be corrected, like your soft tissue correction or hard tissue correction can be done. Soft tissue corrections are like when you relieve the redundant tissues, flappy ridges and everything that will come under your soft tissue correction. And hard tissue corrections are like you have some kind of tuberosities or something like that over your, especially your mandibular region or maxillary palatal region and everything, which is hindering your denture placement. Then you have to remove those kind of poly tubers. Then alveolar ridge extension is when you have to extend the entire ridge. And then there is augmentation when you have to increase the whole thing by adding some kind of graft or something like that. So it's basically augmenting the alveolar ridge. And further about it, we'll discuss later.